run through, I've got some pre-prepared questions which I'll throw out to everyone, but really, really keen to hear from yourselves what what questions you may have, or any follow-up, or anything that you would like us to kind of touch on as well. We will do our best to fit that in. But I will run through one by one. Anastasia, I don't know if you're happy for me to start with you.
Yeah, sure.
So just talking about really just the general use of telehealth, but are there any particular kind of scenarios, particular kind of issues that you find are especially well suited to telehealth as opposed to sort of more standard face-to-face?
I think the classic one is anything infectious disease related, so you don't want to be going out and spreading it to yourself and others. I think the other one would be emergency consults, because although we have a subscription to locums, for example, and they can come when we're not able to, it's actually quite difficult to get them even within hours, and sometimes it just won't, like they just can't. And if the patient is someone, like you see them frequently, you know them off the top of your head, sometimes it's just easier to deal with the problem. Avoid hospitalization, avoid getting a locum involved, avoid, like just fix it on the spot. So that's been really nice to be able to look after patients that way, because at the end of the day, that's kind of why you do it. Like you know your patients well, and you can help easily.
And I know that's always what's driven this, is really keeping people out of hospitals.
Yeah, because a lot of the time, if the nursing staff aren't sure and they want to be doing the safest choice, and sometimes that is calling the ambulance after hours, but maybe not super appropriate. If you can kind of talk to the clinician that knows them and sort it out.
Absolutely. Thank you. I might throw the same question to you from your perspective.
Yeah, I think it's been very beneficial for residents who have delirium and they're unwell, and you know, like the nurses know they don't really need to go to hospital, but they need a review, and getting the GP onto a telehealth is much easier, because as you said, you know your residents, you know what's normal for them. Just looking at them, often the GP will go, so, and we try not to rely on locums as well, because locums are very limited in what they want to do sometimes. They're like, we don't know the residents, and they're really reluctant to change some things. They'll do the Band-Aid approach, might as well send them to hospital. So it can be very difficult. I think for those with falls as well, it can be really good, and with wound management, it's been really helpful when a wound's deteriorated. You just want to show the doctor and say, what do you think? And just get that second opinion straight away.
While you're doing a wound dressing, instead of having us come take it down after you've just done it.
It's all ready to rock. Exactly, and they come at 6 o'clock. So so it's during the day when it's appropriate. The resident's in a good mood. It's a good time of day for them as well. And I think that it just speeds up things, rather than absolutely, it's 6 p.m, there's one nurse on duty, and the GP wants to do a round for unwell people when it could have been done at 10 o'clock via telehealth. So yeah, I think that's been some of the benefits.
Fantastic, thank you. And always like having follow-up questions. I'm interested in your first example of of patients with delirium, and I wonder if, as someone who's completely naive, as not a clinician in any sort of way, do you find a value actually in having that as a telehealth for the patient's kind of interaction as well?
Yeah, we've had feedback from even residents with a cognitive impairment. They feel like they're in the meeting, rather than when it's a phone call and the nurse is ringing the doctor, hi, I've rung to talk about, they're totally removed from the conversation. So when they actually can see themselves, some of them are very, very entertained with the screen and what's going on. It's a great distraction. But yeah, they go, this is good, is that the doctor? And they seem to be able to engage, and I think that's a benefit. So yeah, it's, you don't want someone with delirium in an ED, because it's just the worst environment if you can prevent it.
Thank you. Yeah, now with thoughts in my head around being able to see yourself and how valuable that can be, but I'll say that. Rhian, I don't know if there's anything you'd like to add on to that.
So, as you've been talking, I was thinking, save the patients that indignity of how long they're going to be in ED. You know, that's a massive suffering for people to be up late in an uncomfortable place. They're often going to deteriorate just even by being there, to see a doctor quite briefly and then be sent home maybe 8 to 10 hours later. So I think if we can be avoiding those kinds of things, there's definitely a value. In terms of my perspective, because I don't work in aged care, and looking at the usefulness of telehealth, you know, it's that distance thing. You know, this can be used anywhere. You can't easily get a doctor to be. And so when I use it, it's to cover regional prisons, or, you know, but you could use it for small town GPs. So, you know, those ones that are always advertising in newspapers, they're going to pay a GP $1 million and give them a house and a car, but they still can't get one. You know, they could be running a telehealth clinic a couple of days a week and getting their patients, their residents seen. But, you know, I think we need to be thinking about telehealth and how it can work in a supported clinical way like this.
Fantastic, thank you. Yeah, and again, you mentioned particularly that kind of acute emergency care, where we now do have, there's a virtual emergency clinic that's run by WA Health, and so it does feel like a wider kind of move towards it, which is, from my perspective, very good. Rhian, I'll stick with you for this next question, and it's around your practice quite specifically, and for yourself and your practice. Kind of what would you say are some of the key benefits that have come from, you know, a wider uptake of telehealth?
Again, it's being able to access people that you couldn't normally. So, you know, if I'm doing a clinic to people in Roeburn, when I'm sitting in Perth, you know, and making sure that you can do some work for the days that you're going to be there later, for instance, you know, knowing that hopefully you can get out there, and if there's things that you wanted to see face to face, you can fit them in, but you can almost triage some of the stuff that you can get done by telehealth, and not have to do everything on the days that you are there, because you can't do everything all the time. But it just gives you a bit more time and a bit more access to places that are difficult to get to.
And then presumably, like, being able to spend more time with the people that do need that extra kind of care.
And coming up on the thing that you said about people enjoying it, what I've found over the years is people are quite comfortable talking on screens. And that seems more so, and I think that will really grow. You know, it will be what, you know, our kids have always done it. And you wouldn't expect older people to be comfortable with it, for instance, but I find that actually most people do chat, and you can build rapport, and you can joke and be sensitive and do all of those things.
Yeah, I think they're more tech savvy than we think sometimes. Like,
With the support of the nursing staff as well, that will help facilitate. And I think that's the other thing, like when you've got people who can't use the technology, they kind of miss out on that. So having telehealth that's nurse facilitated inside a nursing home gives them the access to faster care rather than depending on their relatives coming in and stuff like that. And the nurses get a handover at the same time, they know what to do next at the same time, and it's quite nifty.
And I think COVID was handy in the sense of technology.
It really pushed it.
Yeah, it did. And I know my nana. My nana passed away a couple of years ago at the ripe old age of 109.
Wow.
She loved technology. Wow. So I'd go in with my laptop and I would FaceTime my brother in London. And she was like, I can see Peter. Like, she loved technology. So I think going through COVID, a lot of the older people were introduced to technology and that. So now it's just that extension, and yeah, it's, you know, it's made it a lot easier, but yeah, some of them are smarter than we think, or they actually really enjoy it. So yeah, I think that's
like your
good.
little speaker, the little handheld
It's
speaker.
really good, yeah.
Yeah, because I think that is one of the downfalls if you don't have everybody being able to hear each other clearly. That's when everything else gets a little bit worse.
Yeah.
So to be able, because you know, if you've got background noise, that can get in the way of people being able to hear each other well. And I think that's a really valuable little thing that you've got on your cart there.
And it's got really good sound. You know, it picks up the sound really well, and you know, provides sound really good.
And I know when we were looking at all of the different options, there was one of the things that we absolutely were very keen to ensure was that it would be a kind of an inclusive piece of technology. It's not, in some ways, there's the easy way of just sort of saying, here's an iPad, you can use that, but that's very much a kind of an interaction probably between the nurse and the doctor, which doesn't include the patient. And you know, updates aside, it's fantastic that we can kind of show the patient, include the patient in that, or the resident in that conversation, absolutely. And the sound, as you say, it's talking with, not talking about, I guess, that sort of concept.
Yeah. But having a nurse there as well, and just that support, so they can notice if you're not hearing each other and help a little bit, you know, and they know the resident, and they can sort of reassure if they're feeling a bit challenged by the whole thing. I think it works really well to have that team doing it together.
No, and it takes a lot to bring a team together sometimes to get everyone working with it, but certainly it sounds like when it works fantastically. I wonder, just, I go off script, people give me these things and I just don't want. I wonder if along those same lines, have any of you had any experience of kind of bringing family into that equation as well?
Yeah, I think we have. So we've got a couple of regional homes. So we've got one in Broome and one in Kalgoorlie. And one of the benefits is accessing, you know, there's not every specialist in Kalgoorlie. And in Broome, there's hardly any allied health. So, you know, when you want a speech here, you've got to wait. You know, if you want a podiatrist, you've got to wait. So having that opportunity, but also the family can dial in, you can link them up, they can attend to the clinic as well. So we've had some family who live over east. And they want to be into the conversation, especially if someone's palliative, and you want to have some of those conversations and you don't want to do it over the phone. Having them dial in and be part of that clinic is really beneficial, and the family feel like they're there. So, yeah, and the residents like it. You know, half the time, is that my daughter speaking? You know, they get a bit confused sometimes, but is that my daughter there? So it's, so they have a little chit chat, and then you eventually get to what you should be doing. But that's really good because it makes the family feel more involved, and then it's a three-way conversation rather than it's the resident misses out. They miss out every time if you're on a phone, even if it's on speaker. So they feel part of it, and the family can engage a lot more. So yeah, it has had those definite benefits with families.
Fantastic. Yeah.
Great for families as well.
Yeah, because not everyone lives in Perth and is available at 10 o'clock on a Friday. So, you know, they're
nothing
working.
Worse as a relative trying to get information from your elderly parent.
Yep. Yeah. And getting the right info. What did the doctor say? Nothing. And it's like, so yeah. So yeah, it's sort of, it keeps families engaged. You know, and the feedback is more positive because if you actively engage people, one, your complaints go down, two, they're up to date, they actually know what's going on, and everyone has the best intentions. And sometimes when families get angry, it's more because they don't feel like they're in control or they're engaged. So yeah, it does make it a lot easier.
Thank you. So obviously, I mean, this is the fantastic experience. Things are working, everyone's happy, and it's the new way forward, and we're going to use it for everything. Obviously, that's not the case. And you know, I think one thing I normally would do right at the beginning of anything like this is just to sort of say telehealth isn't for everything. It should not be for everything, and it never will be. But even for those things that it is absolutely for, and you're finding the value in, I'm going to guess it's never been an easy, instant way for using it. So, like, if you had to pick a key, like the one biggest hurdle from each of your kind of positions that you've had to get over, so Anastasia, starting, what was the hardest thing that you found?
Not having a battery. Look, no, apart from that, look, it's all getting fixed. It's all going to get
Let's
better.
concentrate on that one.
But fun fact, the rebates are not different on a weekend to a weekday.
Now my
So
follow-up to that
does it-
question was going to be, how have you come over that hurdle? I think that might be one that's...
It's an annoying thing when you
Mm.
can't get over the hurdle. At the
Mm.
end of the day, if I get caught up in the middle, like if like for example, I am always on call for my palliative patient. Like it's, I don't want the locums. I don't want them to go. It doesn't matter what time you call me up. So I'm happy to take those calls and take a, like, I guess it's a hit on my end financially. But at the end of the day, when you look at the rebate for a one-off consult for an emergency, middle of dinner consult, it's like $20 or $30 in your pocket. Like, you're going to interrupt your dinner with your kids to deal with the patient. Like, I love my patients, but I also love my kids. So that's a little bit tricky. So you have to start putting boundaries in place, and so sometimes it does detract from the use of it, because you will eventually burn out that way if you don't have enough value.
I can understand that. So in some ways that's the availability of telehealth.
So it's also kind of making sure your staff are aware that it is like in the middle of dinner time, a real one-off or an emergency thing. Trying to avoid hospital but like at the end of the day, it's never going to be an everyday thing unless it's going to be a chunk.
Thank you. Again, as a non-clinician, I can't even begin to imagine that scenario. So, same from your side.
I think the biggest issue we had, you mean with the carts?
Yeah, just sort of
use?
those initial hurdles that really felt.
Yeah, IT was an absolute nightmare. So we had an IT manager who was scared that they were going to kill the whole network. So we couldn't connect to. I know, like it's just I'm a nurse, not a.
The panic that he must have experienced.
Look, he left soon after, thank goodness. But we couldn't get the Wi-Fi. You remember, we couldn't get the Wi-Fi. I had to buy dongles and all this sort of crap because he wouldn't let us use anything that connected to the system. And I was like, "You got to be kidding." So once he left, remember in Kalgoorlie, we're trying to connect. We're hotspotting phones and things like that. So I think in the beginning, being able to, because the Vision Flex was a little bit tricky and it really drained any system that Wi-Fi that you used, it killed your data. So in the beginning, that was really difficult. So everyone just went too hard, can't connect to the Wi-Fi. We couldn't access email. Just that setup was disastrous. So once we got IT sorted, we liaised with Whopper and sort of troubleshooted a few things, made sure we had the updates, because that's a real pain. You turn it on and it goes, you need an update, and it's like, oh my gosh. So I make sure everyone does their updates frequently. The batteries, we have the batteries now, so that is a lifesaver. But yeah, the IT issues in the beginning was the nightmare. So yeah, you're raising your eyes and it's just like, I said, I don't understand. And so that was, having a login, trying to get into it, all that sort of stuff was the biggest issues. I don't know if you girls found that problem as well, but it was just our IT. So if I could roll back, in the beginning, knowing more now and having support that was logical, we would have been home and hose, but it really put us behind building the confidence of staff to use it without the barriers of Wi-Fi and hotspotting and everything else.
And I think confidence is probably the
confidence is number one, because you can pick up the phone, you can dial the doctor, hi, it's done. The cart, you've got to get it out, you've got to turn it on, it's all that logistics. We're using the Health Direct platform now, so I've set up all our homes with their own clinics. They can do it and they're all actually using it. The uptake is so much more using the Health Direct platform because it is 50 times easier, so much easier.
It's removing those barriers.
Yeah, but the IT barriers were very interesting.
I've worked in this space long enough to not be at all surprised by that.
Oh, there you go.
Unfortunately.
Yeah.
Rhian, for yourself.
Very interesting to hear all those IT issues. It's just so typical, isn't it? You've got this marvellous technology and
I know.
people just can't quite do it. For me, some of the downsides I've had in the past is, we're talking about using this to overcome tyranny of distance and availability, that, like you said, telehealth is not for everything. So you have to be able to sometimes get to site. And you have to be able to say, well, I need to eyeball that. And if you haven't got that backup of being able to sometimes get there, you're in a very clinically vulnerable space. And that's sometimes been very challenging. If there's nobody else going and I'm not going, what do we do then? So that's one challenge. The other challenge is, we've talked about how accepting people are, but we also have to accept that for some people this isn't going to work, and it's not culturally appropriate, or the sensory issues, they just can't hear, or it's too new and scary, and be mindful of that, really.
So I guess what I hear there is there's not a one size.
No, it's general practice.
Absolutely, yeah. But it sounds like you've set those kind of boundaries in a sense for yourself. Is that something that
I
needs
think
to do?
you just have to be mindful, really. You can kind of go, well, once you get there, if this doesn't feel right, either the patient's not connecting in that space and it doesn't feel right, we're going to have to schedule something else. And if there's not the availability of clinics to get to that spot, who's going to make sure that they do? That's where you can come up with challenges along the way. And especially if you've got sort of nursing homes where you've got no GPs, and you've managed to get someone to cover a couple of telehealth clinics, but you've still got someone with something that needs someone to lay their hand on it. It's a challenge, and these are the things we do.
Thank you. Sort of based on some of those experiences, kind of the flip side to that question of what's been the hardest thing to come over, from your time kind of getting set up with this, becoming more of a daily kind of or regular use for you, what's the one thing that you would suggest to anyone who's looking to do it? What would be the first thing that you would suggest they consider or do? And Rhian, I'll start with you.
So I think, you need someone like Diane who's going to be there on the ground, who's enthusiastic, who's going to make sure that the staff are trained, and that if one member of staff who's good at using the cart leaves, that the next person comes along isn't going to go, oh, well, so-and-so did that, but I'm not really into it, so I'm putting it in the cupboard. Those kinds of things. And then really it's overcoming all your technicalities, making sure if you're bringing your residents to a space, that it's a space where it's private, it's comfortable, there's good sound, there's not a lot of background. You don't want a digger outside. People shouting. We don't want it to be next to the bingo. Whatever things you can try and sort of make sure it's easier for everyone. And then you've got to have your setup for how you're producing scripts and requests and how you're getting them to where they need to be, and whatever things you need your end. I don't know how you manage yours.
All electronically.
All electronically.
It took a while to kind of get into it, but I think I've got even the ones who are threatening to retire on board. So good job. Thank you.
So on that subject, would you say that was a very similar experience to yourself, Anastasia, in terms of?
It is. It's more kind of trying to work out what you need from it. And everyone's going to be really different about it. And so I talked about the boundaries in dinner, and I think that's a really big thing about some of my colleagues, that they don't want the interruptions, so they're not, they're just keen to do their usual routine thing. So it kind of depends on what you're looking for your practice, and trying to establish that and your boundaries and your team who's going to look after it. And oh my God, the IT sounds horrible.
It's good now.
So both, so I'm hearing kind of from the relationship side of things, so working closely with a residential home.
Because it's never going to work perfect. It's always going to be like a dongle missing.
Or the pulse oximeter's going missing.
I need to be tied down.
I know. I order, I sound like a mag sometimes. Have you labelled it? Yes.
And then also as well, that kind of actually having quite a clear idea of exactly why. You know, what is this? What are we aiming for here? I think that's really interesting.
Because that's a discussion within that partnership with the nursing home as well, is so they know where your boundaries are and what you can do. Otherwise, you might get annoyed and just abandon the whole thing. So kind of saying, look, in this instance, it's really good to have this telehealth. Can you make sure it's ready, available for this reason, and kind of sell it that way and establish your boundaries that way.
And I know one of the suggestions that we always say to practices in residential homes who are looking potentially at using the equipment, you're building a bit of that relationship, is just try and have some fake consultations and just really kind of have a practice run at using the technology. And if it doesn't work out and the sound's not great, or some of that technical issue, it's an experience, something that you can work through together at that point. So
I'm sure your residents would love to be little actors, wouldn't they?
They actually engage really well. Like, the residents aren't the problem, it's the nurses sometimes. It's like, it's like in the beginning we had them locked in nurses' offices, and it's like, where's the telehealth card? Oh, it's in the manager's office. Well, can you get to that after hours? And, things like that. And
What's the login?
yeah, that's right. So we've got a generic login, so trying to, an agency, when you've got agency staff, no way are they going to touch it. So now the resources in their agency file, so they can't say they didn't know. It's on their checklist and it's in their file. So the cheat sheets are all laminated and on the side of the cart. So, you try and, did you like that idea?
That's copyrighted?
Yeah.
You're going to have to...
So we have an agency resource file, and we've put the telehealth stuff in there so that they know, because it's usually the agency that has it, that they need, especially for an emergency. Like we use Waved for all our emergencies. We have the problems with the paramedics. They come along and they sort of, no, we're not using the cart, and out comes the iPad. So that's a tricky one, but if the nurses have got it set up, it's okay. But yeah, it's getting the nurses confident. That's been my biggest barrier, is the nurses' confidence in turning it on. Now we have the easier login and Health Direct. Agency staff are using it. We've got one site and they seem to be using it because I think they're working across other organisations that are using it now. So it's the same piece of equipment everywhere. Not like some other pieces of clinical equipment. It's different. It's the same thing everywhere. So yeah, it has made it a lot easier. So those sort of things.
And again, I'd probably say there's a bit of a relationship there as well, isn't it?
That's a lot of work from your end.
It's a lot, and I unfortunately have to report to a committee with the CEO, and I don't know what it is, but she's just obsessed with telehealth. So how's the telehealth going down? And I was like, so I've always got to come up with something really good. But you can get great stats from Residential Care Line. I can get all the hospital admissions from Waved, who's been waived and who hasn't. So I've got a bit more data, so that really helps with, promoting and encouraging. And we're transferring the right people. So we're transferring the right residents to hospital after a waived consult. We're not having those unnecessary transfers because we've had a waived consult and it's stay at the facility, which has been really beneficial in them sending someone and they're sent back again. They're just like in ED, they've driven them nuts and they're back again and they haven't been treated. So it's prevented that unnecessary hospital transfer that doesn't result in an admission. So that's been one really, really big benefit.
And I suspect that when your staff see that benefit is there, then it's a kind of virtuous cycle, I guess.
Yeah, especially when they're reporting, like the clinical nurse managers are reporting on, unplanned transfers and things like that. It looks so much better if their data is nice and low, and they've kept people safe at the home. So they've been treated at their home, rather than being transferred for treatment that could have been done. And with the extended care paramedics, it's easier. You can keep people a lot better. So it has made a big difference.
Fantastic.